Hello and welcome back. I'm your host, Dr. Edward Halperin, the Chancellor of New York Medical College and the Provost for Biomedical Affairs of Touro University. And it's 90 Minutes, the medical magazine of the web. And we're here with webinar number 33 as we continue our series of information both to help healthcare practitioners take care of their patients and provide interested non-healthcare practitioners the information they need to know to be informed patients and parents of patients. Our topic for webinar number 33 is about your immune system and how your immune system responds to external assault. I have titled it Bugs, Drugs, and Us, Infections, Treatment, and the Immune System. As always, we've got a collection of your old friends and some of your new friends that you'll be making today for the webinar. We're going to start off with a topic which is on the minds of a lot of people. It's time to go get a shot in my arm. Which vaccines do I need this time? We're going to focus on this season's flu vaccine, the new COVID vaccine, and the RSV vaccine. And we've got America's infectious disease specialist, Dr. Marissa Montecalvo, back again, and America's family doctor, Dr. Laurie Solomon, back with us again. We know these are your fan favorites. A lot of people write it and say they don't care what the CDC says. They don't care what the FDA says. They're not doing anything when it comes to vaccines unless Marissa and Laurie say it's okay. So we're going to have a panel discussion with Drs. Montecalvo and Solomon about these three vaccines and what we do know and what we don't know, so you can make an informed decision about vaccinations this fall and winter. Continuing on the theme of bugs, we have a return visit from Dr. Solomon Amar. He's going to tell us what the latest information is on monitoring outbreaks of infection by studying wastewater. We learned during the COVID epidemic that you could ascertain the frequency of certain infectious diseases by measuring sewer water from a populated area, and not only, for example, detect COVID, but identify resurgence of polio in some communities. He's going to bring us up to date on this fascinating area of research. And then fan favorite pediatrician Dr. Tammy Hendricks is back with us to talk about a very common problem. You think your child has a cold, you take them to the pediatrician. The pediatrician says it's a virus, they don't need antibiotics. And then comes the almost inevitable question, aren't you going to give my child a prescription for an antibiotic, doctor, just in case it's bacterial? Well, of course, we've got the problem of the development of resistant bacteria from overuse of antibiotics. And Dr. Hendricks is going to talk with us about this issue and the practice of pediatrics. Then turning to the immune system, the way our bodies respond with immune surveillance and defense, we have two new friends for you to make today. One is a specialist in multiple sclerosis, Dr. Stephanie Gandelman of Westchester Medical Center. There is a hot topic in multiple sclerosis, and that is the so-called concept of de-escalation. For people who have been treated with multiple sclerosis drugs, sometimes for decades, do they get to a stage in life, typically as they age, where their immune system tamps down and you can start removing some of the drugs from their treatment program? Dr. Kahneman's going to fill us in on what's new in this area. And then finally, we have someone new for you to meet, Professor Aaron Yankowski of the Touro College of Dental Medicine at New York Medical College. And he's going to talk with us about an interesting evolving topic, What do we know and what don't we know about oral health for people who have been chronically on drugs for autoimmune disease, and how does it affect their teeth and their gums? People with rheumatoid arthritis, lupus, multiple sclerosis. People who have been taking drugs to deal with these diseases are subject to a variety of dental diseases, perhaps related to the effects of these immune suppressive drugs on their bodies. And Dr. Yankowski is going to fill us in on what we know and don't know about this interesting topic. As always, we welcome your questions for our panelists. Use the question and answer box on your computer screen to type in your questions. And after all of our speakers are done, we'll get to the question and answer part of our program and try to get as many of your questions answered as possible. Also, I will appear in between some of the presentations to tell those of you who want to get your continuing medical education credit how to do so. Welcome back to 90 Minutes, the medical magazine of the web. We hope you enjoy today's program on bugs, drugs, and the immune system. And let's get started with our first speaker. Hello, and welcome to our first session for webinar number 33 on our general topic of bugs, drugs, and us, infections, treatments, and the immune system. We're going to start by tackling a topic that is on a lot of people's minds. Do I need to go roll up my sleeve and get vaccines this fall or winter? If so, which and in what order? We're going to focus on COVID vaccines, influenza vaccines, and RSV vaccines. And as I promised you, we've got America's favorite infectious disease doctor, Dr. Marissa Montecalvo, back, one of your fan favorites, and another one of your fan favorites, America's family physician, Dr. Laurie Solomon. I don't know about your family, but in my family, it doesn't matter what the doctor says or what the CDC says. Nobody's doing anything about vaccines unless Laurie and Marissa say it's okay. So let's start. For those of you who somehow have missed the previous 32 webinars, let's start by Drs. Montecalvo and Solomon introducing themselves to you. Dr. Montecalvo first, please.
Good afternoon. I'm Marissa Montecalvo. I'm the Director of Health Services at New York Medical College and a Professor of Medicine in the Department of Medicine.
Hi, I'm Laurie Solomon. I'm the Chair of Family and Community Medicine at New York Medical College and the Medical Director of the Family Health Center at New York Medical College.
And for those of you who are easily taken in by background, we assure you that New York Medical College is not located overlooking the Golden Gate Bridge. Dr. Solomon is actually based in Valhalla, New York, and that is not a view of Valhalla, New York over her right shoulder. Well, it's the time and season for another round of vaccines. So, Dr. Solomon, let's start by laying out the background. What's the nature of the problem and healthcare risks for COVID and influenza and RSV nowadays, please?
Sure. Just wanted to let you know that I'm from the Bay Area, which is why I have the Golden Gate Bridge in my background. So that is why. But I'm happy to go through why are we talking about this topic? Why is it important? So I'm just going to share my screen. So what I'm showing right now is is a slide from the CDC that shows the deaths for COVID. And one of the things that you can notice is that at the beginning of the pandemic, we had a lot of deaths, but as time goes by, the death rate has gone down. And this really explains why we're having some of the conversations about whether or not COVID vaccinations are recommended and useful in all populations. We'll be talking about that more through the webinar. The second one is a slide from the CDC on influenza deaths. And you can see during the pandemic, we had very few because more people had COVID. But as we're getting further away from the pandemic, we have a lot more deaths coming from influenza. And you see that last year was a particularly bad year for influenza. We had about 3% of all deaths due to influenza, so much larger than it has been. And so that's something to consider when you're thinking about getting a flu shot. Flu shots prevent death from influenza. So that seems to be a lot more important. And then another vaccine that we've heard not as much about, but that's the RSV vaccine. And I couldn't find the same kind of data from the CDC because of the government shutdown, but I did find this slide that shows the scope of the problem with RSV. And you can see that there are quite a few deaths from RSV, and even more outpatient visits and hospitalizations. And that's why we are recommending RSV vaccinations for certain populations.
Well, thank you, Dr. Solomon. I suppose before we move on with further discussion, it would be important to point out that death rates are not the only way of looking at the effects of these diseases on the population. Days lost from work, days lost from school, numbers of days of hospitalization, economic impact are also things that one could measure, correct?
Correct. That's why I like the last slide about the RSV, because you can see that that for every death, there's a lot more people who have gone to the doctor because they're really sick or they've been hospitalized. So death rates are obviously, you don't want to die from a disease, but but these diseases all have impacts where they can either make you miserable for a week or two, or they can land you in the hospital with other complications.
Hey, thank you. Let's Dr. Montecalvo, before we start getting into recommendations, let's touch on another background topic, which is how come these vaccines keep changing? How do we decide what subtype we're going to have in this year's vaccine compared to last year's vaccine? And how good are we at predicting which subtypes for these viral diseases need to be incorporated in the vaccine?
Thank you. Yeah, so that's an interesting topic. So I will begin that with influenza, where we look to see what's happening in the southern hemisphere to decide to look at what projections for the northern hemisphere will occur. And every year, the influenza vaccine usually always has 3 components and sometimes has 4. So there are 2 major strains of influenza, A and B, and there are usually 2 A components. One is H1N1, the other is H3N2, and 1 B. And then there's what's called a quadrivalent vaccine, where if there's been another B strain in circulation, it's also incorporated. This year, the decision was made for the vaccine to be only trivalent. There is no quadrivalent vaccine this year. So it's 2 A's and a B. And they modified the H3N2 strain to mirror a variant that was prevalent. How good will that be at predicting? It's usually pretty good, with the exception of where something untoward happens and there's a genetic jump, like happened with the swine flu in 2009. For COVID, it's even more complicated because COVID is changing so rapidly, SARS-CoV-2. And so the FDA looks at what they know about surveillance in May and makes a recommendation to the vaccine manufacturers. And some surveillance activities have been greatly curtailed compared with what was going on during the pandemic. but they make a projection based upon that. But as you know, SARS-CoV-2 changes often. And so I think it's a little harder to get it. But in general, the vaccine efficacy is still quite good. For respiratory syncytial virus, we don't have as much variation. I do not think that vaccine is modified year to year in any way.
And there is at least one other point about these types of vaccines, Dr. Solomon. Let's talk about why it matters what your age is when you go for a flu vaccine and why one gets one or another vaccine based on the age.
So as we get older, our immune system gets a little bit slower to respond to vaccines. And so as you get older, you need to have a little bit of a higher dose of vaccines. So we use a high dose vaccine for individuals who are 65 and over. And that just gives a little bit extra boost to the efficacy of the vaccine. For anyone that's 6 months to 64, we use a regular dose vaccine, influenza vaccine. And then if you're afraid of needles, we do also have a intranasal vaccine that can be used. That's a live virus vaccine, so it's very different than the ones that we use as injection. It can give you some mild flu-like symptoms after having it. So you can't use that in somebody who's got problems with their immune system, but it's an acceptable alternative for especially children who don't like to get needles.
Thank you. Dr. Montecalvo, how does the timing of the COVID vaccine get done if you recently had COVID?
So the recommendations remain that as they've been in the past, which is that if you've had natural infection, that you've had COVID, you are thought to have protective immunity for a good 90 days. So I think if you are planning to be vaccinated against COVID, but you had natural infection, I would wait the 90 days. And the reason for that also is because to wait would be also has to do with timing of what's the best time to get your COVID vaccine. So, you know, the immunity from COVID vaccination is not all that long lasting, as we know. And really, it's the 3 to 4 to maybe 6 months after vaccination where you're most protected. So you want to time that well in terms of your risk. So in the Northeast, those are the winter months, right, that we're going to be more indoors. And so if you hadn't had COVID, maybe you want to get vaccinated in November. If you've had COVID, maybe you can delay that some. You don't have to wait 90 days, but you can wait 90 days.
Well, Dr. Solomon, Dr. Montecalvo's teed up what would seem to me to be the obvious follow-up question, which is, if the family's all getting together for Thanksgiving or for Christmas or Hanukkah or Kwanzaa, assuming that we actually end up with airplanes that fly in the United States in the next couple of months, what would you recommend to patients if people are coming from all over the country to get together at Aunt Loretta's house for the big family get-together for the holidays about being vaccinated before you get to encounter bugs from all over the U.S. around the dining room table?
I would recommend anyone over 6 months of age get a flu vaccine. The COVID vaccine, I think it really depends more on your age, whether you've had COVID, what your other medical conditions are. And for RSV, there are age recommendations. So 60 to 75 if you have some chronic medical conditions, and then if you're above 75, everyone should have it.
Dr. Montecalvo, how worried should we be about Guillain-Barré syndrome and the RSV vaccine?
Well, it is in the most recent reviews that were done of RSV. It was a higher rate than previously. So, I think it really a respiratory syncytial virus vaccine is a vaccine that is really for particular groups, as Dr. Solomon has already said. I think that if you're at high risk, I don't think that the numbers are so high that that would keep you from taking the vaccine. But I think that, people do need to be aware that the numbers are higher, certainly, than they are for COVID or for influenza.
The other group that needs RSV vaccination is women who are pregnant. And that's not really so much to protect the pregnant women, it's really to protect the baby after birth. And so that's another group, newborn infants that have a higher rate than normal for dying from RSV. So that's the other group that I didn't mention for RSV vaccination.
And that's in many ways the most important group, because it is those babies that will die. And right. The vaccination of pregnant women has really changed that. And there also, of course, is a monoclonal antibody available for the same group.
We've covered a lot of ground. The time has, as usual, flown by. I want to thank Drs. Montecalvo and Solomon for chatting with us about these important topics. There are, I'm sure, a lot of questions from our audience about what we've touched upon. Be sure to type your questions in the question and answer box on your computer, and we will get to as many of them as possible in the Q&A part of our program. Thank you, Dr. Solomon. Thank you, Dr. Montecalvo, and we will continue with our program.
Thank you.
Thank you.
Hello again. This is your host, Dr. Edward Halperin, with information for how to get your continuing medical education credit. For those of you looking for credit, we, as always, have several ways to do so. You can get out your cell phone or your tablet and send a text message to 828-295-1144, 828-295-1144, and put as your text message 05 LISP, all in capitals, 05 LISP. And if you do that, you're going to get a text message right back, and it will take you to a link to fill out your audience satisfaction questionnaire and get you your CME credit. If you don't want to do it that way, you can take your device and scan that QR code on the right side of the slide, and it will also take you to the website to fill in your audience satisfaction questionnaire and get your CME credit. Whichever way you choose to do it, get about your business and do it, because these codes are going to expire on Sunday, November 23rd at noon. As always, if you have questions for our panelists today, type them into the Q&A box on the bottom of your screen. We'll get to as many of them as possible during the Q&A part of our program. And let's get back to our program.
My name is Salman Amar. I'm professor of pharmacology, pathology, microbiology, and immunology at New York Medical College. And I'm happy to provide the updates as it relates to monitoring infectious diseases in the community with wastewater measurement. I have no conflict of interest to disclose, except that ChatGPT was consulted to validate some factual facts. Wastewater-based epidemiology, known as sewage surveillance, is a powerful public health tool that detects pathogen in the community wastewater using PCR amplification of DNA elements that you find in the sewage system. It identifies viral, bacteria, other microbial, genetic, anything that has an RNA or DNA shed by infected individuals. often before the emergence of clinical cases, and that's probably the most important factor to consider as an advantage of the technology. It was very popular during COVID-19 pandemic, but it was used prior for polio monitoring. Why specifically wastewater, and what are the key advantages? Early warning. It is reported that up to 1 to 2 weeks prior to a hospital reports, this technology is able to detect the mRNA of microorganism in the wastewater. It affords proactive response like targeted testing and vaccination, as we did in 2020 for COVID-19. It's population level insight that captures the data from entire community, schools, cities, very anonymous, regardless of symptoms and testing access. It's very cheap, can be automated, a large throughput screening, sample of large population at very low cost compared to individual testing, and it has an environmental monitoring. It does track antimicrobial resistance that is very important for hospital, emerging variant that we had in Omicron, if you remember, with COVID-19, as well as zoonotic threats that happen with animals. Quickly testing method using, in a nutshell, nucleic acid extraction. The detection can be either by qPCR, digital PCR, very mobile technology, or next generation sequencing. And yes, the data is the data analysis that is done with using bioinformatics. What are the challenges and the limitation of the technology? The DNA is shed into an environment that is against the DNA. Specifically, it has harsh pH. Enzymes are available to degrade nucleic acid, and is mitigated by rapid processing. Quantification issues doesn't distinguish between active versus past infection. Flow variation affect the trends. Equity gaps, urban bias, rural and decentralized system is harder to monitor. Regulatory hurdles, data sharing and standardization vary globally. The WHO guidelines emphasize harmonization, and we're trying to reach that level as we engage into a more broader analysis of wastewater using the same technology but for different microorganisms. Let me just give you briefly what we have been done at the New York Medical College COVID-19 wastewater surveillance. It's a project by the New York State on COVID-19. The project is administered, it's a CDC grant, but administered by New York State Department of Health at Wadsworth Center. 4 academic laboratories called Centers of Excellence: New York Medical College, SUNY, University of Buffalo, and University of Rochester. And you see here on the screen specific areas by which the sampling is done and recognized by GPS technology. Here on a sample collection, wastewater testing by county, we are in the bottom of the state distribution, affecting, and our samples come from 7 counties: Westchester, Orange, Sullivan, Dutchess, Putnam, Rockland, and Osters. It affects, or it covers 15 million people living in the New York State, participating 59 participating counties, and we have 154 participating sewer sheds with 40,000 samples that are collected on a regular basis. All this goes to being collected at Wadsworth Center and New York Medical College, SUNY, University of Rochester, University of Buffalo submit on a weekly basis data to a bioinformatics center at Wadsworth Center. All this is prepared by after RNA extraction and given in specific and stringent laboratory controls that are provided by the Wadsworth Center, but implemented at different center of excellence that we have. On average, we analyze between 52 to 60 samples per week, and all this is shipped to New York Medical College on weekly on dry ice. Every single shipment contains a manifest so that we can recognize the nature of the samples and bring that back onto the geographic distribution of the samples, and this is given back as to a sequencing lab. This is the machine. It's a robot, Genexus integrated sequencer workflow. It provides CDA synthesis, library preparation, template preparation, sequencing run. It's a beautiful machine that can give on a 24-hour turnaround between 24 to 40 samples, complete sequencing. The result is a generation of a report that can now be uploaded as a summary report for each sample in a state portal, and all this is given to bioinformatics, and the report is given for the full analysis. Sequencing results are given to a state portal. Weekly results submitted by New York Medical College to New York State Department of Health. State level integration implies Department of Health compiles all the results and generate a statewide variant trend and infection signal. It's a very versatile, sensitive technique, quick turnaround, sensitive. It requires 1 nanogram of nucleic acid, and it can be used with different type of primers, capable of detecting different microorganisms for different applications. We used it for COVID-19, but we're moving with enteroviruses, influenza, RSV, also for some hospital antimicrobial resistance. It's a metagenomic detecting resistant genes such as MCR for colistin. It was the last resort antibiotic for treating gram-negative bacteria. So anytime that we see this antimicrobial resistance is the bad news for different hospitals. Emerging threats, monkeypox, avian flu, H5N1 monitored in US and in Europe. And recently, with the advent of AI allowed integration of predicting modeling, and now we have 80 to 90% accuracy. Finally, Genexus application implies or can be used for influenza, polio, measles. Other application is cancer. Several panels already exist for specific cancers. Oncomine, and the last aspect would be for mitochondrial tDNA variants that we could have. Let me just acknowledge and give a acknowledgement to the Genomic Center, a center of excellence that we have at New York Medical College. Ravi, Deepali, and Mohana Priya are the people that have done the work and continue to provide this data for New York State. They're funded by the CDC grant contract administered by the New York State of Department of Health. Thank you very much for your attention.
Hello again, this is your host, Dr. Edward Halperin, to talk with you about how you can give back to New York Medical College for today's webinar. You're hearing about cutting-edge medicine today, and not only about clinical practice, but fascinating research projects, including the study on the use of wastewater for monitoring infectious disease. We give the CME credit for these programs for free, but preparing these programs and doing our research are certainly not free. They take time and effort. We hope some of you will consider making a tax-deductible gift to New York Medical College to help offset our costs and support this research. Great things are happening at New York Medical College. We hope you'll want to be a part of it. In order to make a donation, you can phone 914-594-2720, and a happy person from the college fundraising office will be delighted to take the information and your credit card number. Or if you'd like to do it online, go to www.nymc.edu/give to make your donation. For those of you like me who still have a pen and a checkbook, checks can be made out to New York Medical College, put on the memo line that is to support the webinar program, and put in an envelope with a stamp and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for considering making a donation and thinking about the good work we're doing here. Everyone stay safe, and let's continue with our program.
Hello, my name is Dr. Tammy Hendricks, and I'm the campus provost at Touro University, California, and a pediatrician. Today, I'm going to be talking to you about the antibiotic dilemma and why sometimes doing less is healing more. The questions that we'll be answering in today's presentation are, aren't you going to give my child a prescription, doctor? And are we overprescribing antibiotics for children? I have nothing to disclose for this presentation. So first, let me paint the scenario. It's 8 p.m., your child has a runny nose, a cough, and a fever. You've waited for hours, only for the doctor to say, "Good news, it's just a virus." Does that sound familiar? This is such a common scenario. Parents want to do the right thing to help their child feel better fast. I empathize with that. Our job as clinicians is to help families understand that not every fever needs an antibiotic, and sometimes the best medicine is time and care. Here's where we separate myth from reality. Antibiotics are amazing for bacteria, but they don't do much for viruses. Antibiotics help with some ear infections, with strep throat, with some pneumonia, with urinary tract infections, and some skin infections. Antibiotics don't help with colds, flu, bronchitis, most sore throats. If it's viral, antibiotics are like trying to fix your Wi-Fi with a hammer. There are a lot of reasons for overprescribing. Many common illnesses, such as colds, sore throats, bronchitis, are caused by viruses, not bacteria. Antibiotics are only effective against bacterial infections and don't have the effect that we're looking for against viruses. When it's difficult to immediately distinguish between a viral and bacterial infection, a just-in-case mentality can lead to unnecessary prescriptions. Sometimes parents may pressure physicians to prescribe antibiotics due to the belief that it'll help to speed up the recovery, even when an infection is viral. There are some studies that suggest that overprescription with antibiotics occurs more frequently in telemedicine visits compared to in-person visits. So what's the problem with overuse? Antibiotic resistance is like a silent pandemic. I like to tell parents, each time we give antibiotics when not needed, bacteria get smarter. They evolve. That's why we now have superbugs that no antibiotic can treat. So preserving antibiotics is like guarding a rare treasure. By 2050, antibiotic-resistant infections could kill more people than cancer. This is how antibiotic resistance happens. We start with a lot of germs, some of which are drug-resistant. Antibiotics kill the bacteria that cause the illnesses, as well as all of the good bacteria that protect us. The drug-resistant bacteria are now able to grow and take over, and some bacteria can give their drug resistance to other bacteria. Studies estimate that inappropriate prescribing of antibiotics for common infections in children resulted in $74 million in excess costs in 2017, and those costs just keep going up. So what is the harm for your child? Let's bring it home to a personal level. Overuse doesn't just cause resistance, it can harm your child directly. Even one course can disrupt their gut health, causing diarrhea or triggering rashes. I often like to say antibiotics are like a bulldozer in a flower garden. They wipe out the good stuff along with the bad. Here are some of the common side effects we see with all antibiotics. But there's also the risk of dangerous side effects, like severe allergic reactions or intestinal issues like C. diff infections. Antibiotic prescribing isn't random, it's teachable. When we look at prescribing patterns for antibiotics in pediatrics, the variability across practices is striking. The likelihood of a child leaving with an antibiotic prescription depends heavily on the type of practice. In general, private and community practice, especially those that non-academic and fee-for-service, tend to prescribe antibiotics more frequently than academic or university-affiliated settings. We also see socioeconomic factors play a role. Research shows that children living in higher income, lower poverty zip codes actually receive more antibiotic prescriptions in their first year of life than those in higher poverty areas. So both the practice environment and the surrounding community characteristics significantly shape prescribing behaviors. But here's the good news. These patterns can change. Educational programs for pediatricians and parents significantly reduce unnecessary antibiotic prescribing. Awareness plus education equals measurable impact on prescribing habits. So what parents and clinicians can do? Ask the right questions. Ask, is this viral or bacterial? Get comfortable with practicing comfort care, rest, fluids, giving honey only to children who are over the age of 1 year. Remember that your doctor's goal is to provide the best care, which sometimes means not prescribing an antibiotic. Support clear communication between clinicians and families. Choosing not to overprescribe protects everyone. So you can be an antibiotic hero. Save antibiotics for when they're truly needed. Sometimes the best prescription is patience, popsicles, and love. Together, we can preserve antibiotic superpowers for the future. Thank you so much.
Hi, everyone. My name is Dr. Stephanie Gandelin. I'm an assistant professor of neurology at New York Medical College and an attending neurologist in neurology at Westchester Medical Center, focusing on MS and neuroimmunology. For the next few minutes, we'll be talking about de-escalation of disease-modifying therapy in multiple sclerosis. I have no disclosures relevant to this. So why do we even get to talk about de-escalation of medications in multiple sclerosis? Why do we get to talk about stopping? Well, I think in order to have that conversation, we need to back up a little bit and talk about the treatment landscape for MS in 2025. In the last 30 years, there has been an absolute explosion of medication options for disease-modifying therapies, medications that change the course of multiple sclerosis. And as of this reading, as of putting together these slides, there are about 20 different FDA-approved disease-modifying therapies for multiple sclerosis. And here's a timeline of them shown below. And in addition to that, there are generic and biosimilar options of those medications as well. But our MS medications are not good at everything. As of 2025, what I like to tell patients is that our MS DMTs are excellent at one of three major needs. They are really good at stopping new lesions from forming in the brain. And those lesions are important for disability accrual in multiple sclerosis. However, they're not good yet at repairing old lesions. We really don't have any medications that can repair old damage that has already formed. And they're not terribly good at saving up the progressive physiology of MS either. At the same time, because we have better medications to control disease activity, patients are living longer with less disability accrual than ever in the past. At the same time as we've made progress in the medications for MS, it's also important to keep in mind the disease physiology of multiple sclerosis as well. As we get older in life, the inflammatory activity we see, the chance that we're going to form new lesions, tends to burn out. Alongside these benefits, though, we have to think about the risks of these medications. Risk 1, 2, and 3 are infection. And depending on the medication, it can be specific types of infections, some lower risk infections, some higher risk infections. Some of these medications come with a risk of hypogammaglobulinemia as we're on them for longer. Some of these medications come with a risk of reduced vaccine response and efficacy. Every medication has side effects, and MS disease-modifying therapies are have them as well. And these medicines can interact with agents that are used more frequently as we get older. As we're on more medications, the chance for medication interaction goes up. And then finally, there's the accumulated treatment burden over a lifetime of multiple sclerosis. People are on medications for a decade. There is an accumulated treatment burden that comes with that. So the question becomes, when does the benefit of these medications no longer outweigh the risk? Or in other words, when can we say enough is enough? Well, the short answer is it's not so clear. We know the inflammatory activity of MS decreases with age, but we can't predict this within each individual when this will happen. For example, we don't know that somebody who has had MS for 10 years, for example, won't form any new lesions, or if they've had, or if in that person, they need to have had MS for 30 years to no longer form new lesions. MS is diagnosed typically between the ages of 20 and 50, but so a flare risk for somebody at age 55 may be different for someone who has had the disease for 25 years already, or 35 years already, or 5 years already. So there's a major difference there as well. We also know that between individuals, disease severity is variable. Some patients will have one flare in 30 years, and some patients would have one flare per year, if not for medications. But we call both of these multiple sclerosis. Finally, there are no really clear biomarkers that are ready for wide use to say that somebody is at risk now of having a flare or in the near future of having a flare. There have been 2 studies that have been done in recent years looking at large populations as randomized controlled trials, looking at larger ends for discontinuation of disease-modifying therapy. One is the DISCO-MS study, or the DISCOM study, which is the discontinuation of disease-modifying therapies in MS study. This is a multi-center, randomized, single-blinded study that looked to assess the non-inferiority of discontinuing a medicine versus staying on it. They included any disease-modifying therapy of any efficacy. Their primary outcome was the proportion of patients who had either new clinical symptoms or had a new spot on their MRI over the course of 2 years. And their inclusion criteria was quite broad. They included anybody over the age of 55 with any subtype of multiple sclerosis, only with the rules on any DMT, with the rules mainly being that they haven't had a clinical relapse in 5 years or a spot form on the MRI in the last 3 years. And it's an important thing to note at this point that not every spot that forms is symptomatic. And so it's important to monitor if there are silent spots that form, as well as if there are clinical spots that form. The results of this trial showed that there was a higher rate of new MS activity, either on the MRI or clinically, in the discontinuation group over the continuation group. So it couldn't meet that standard of it not being inferior to stop the medication rather than continue it. The numbers in this group, though, that had activity were fairly small, and most of the events, quote unquote, were asymptomatic spots that formed on the MRIs. There was no difference in progression of MS in these 2 groups. There were a lot of limitations of this study, and there is quite limited generalizability to it as well. There was another study done with a broader age range of patients. This is the DOT-M study, discontinuation of first-line disease-modifying therapy in patients with stable multiple sclerosis. This was a smaller group than the DISCOM study, but it did include a wider age range and was also a multi-center, single-blinded non-inferiority trial done out of the Netherlands. And so the primary outcome was whether there was significant disease activity, meaning a clinical event or MRI or spots forming on the MRI during the time, during the observation period. And for this study, they included anybody over the age of 18 who had been stable on their first MS medication for over 5 years. And unfortunately, this study had to be prematurely terminated because the rate of events, the rate of inflammatory disease activity ended up being above the predefined threshold to stop the study. The challenge with this study is that it was a small cohort and there was a higher rate of recurrence compared to the DISCOM study. And it included younger individuals who had only had disease or had only been on disease modifying therapy for at least 5 years as well. So the question is, if you de-escalate, how do you de-escalate? Well, honestly, it depends on the medication. Some medications for multiple sclerosis are pretty easy to stop, such as anti-CD20s, glatiramer acetate, fumarates. These are medications that you can stop and watch individuals on afterwards. But some medications come with a risk of rebound, particularly the S1P modulators and adalimumab. And in these cases, we have to be very careful about and strategic about how we de-escalate these medications. Most neurologists will de-escalate to a different medication that is safer to stop prior to stopping medication completely. And finally, some of these medications require very specific monitoring with discontinuation. For example, the fumarates and S1Ps, we need to keep an eye on lymphocyte counts. And for anti-CD20s, you need to monitor B cell counts. And the bigger question, who do you de-escalate? Well, it really depends on the patient. And this is where personalized medical care is crucial. It's an area where there's just not a one-size-fits-all recommendation at this point in time. You need to have a detailed discussion about the risks and benefits with the patient. And many patients will really have a strong opinion one way or the other. Many patients, when they got on their medication, that's when their disease really stabilized, and they feel very strongly about staying on it, if at all possible. Other patients will say they really want to be done with medication in general, and you have to, and there's everyone in between as well. And so you have to take these thoughts into account. I tend to broach this topic in older patients who have demonstrated decades of stability on their disease-modifying therapy and who are not experiencing clear clinical progression. But in the future studies focused on different DMT classes and which ones are safer to stop than others would be helpful. And it would also really be helpful for future studies to look at easily obtained biomarkers of disease activity to help us determine who's at higher risk of future clinical activity than, and who isn't. Thank you for your time.
Hello again, this is your host, Dr. Edward Halperin, with information for how to get your continuing medical education credit. For those of you looking for credit, we, as always, have several ways to do so. You can get out your cell phone or your tablet and send a text message to 828-295-1144, 828-295-1144, and put as your text message 05 LISP, all in capitals, 05 LISP. And if you do that, you're going to get a text message right back, and it will take you to a link to fill out your audience satisfaction questionnaire and get you your CME credit. If you don't want to do it that way, you can take your device and scan that QR code on the right side of the slide, and it will also take you to the website to fill in your audience satisfaction questionnaire and get your CME credit. Whichever way you choose to do it, get about your business and do it, because these codes are going to expire on Sunday, November 23rd at noon. As always, if you have questions for our panelists today, type them into the Q&A box on the bottom of your screen. We'll get to as many of them as possible during the Q&A part of our program. And let's get back to our program.
Hello, my name is Aaron Yankowski. I'm a board-certified oral and maxillofacial pathologist and the Associate Dean for Academic Affairs at Touro College of Dental Medicine. And I'd like to speak to you today about what we do and do not know about the long-term effects of immunosuppressive therapy on oral health. Starting off, I have no conflicts of interest to disclose. And the overarching 30,000-foot statement is that long-term immunosuppressive therapy is indeed associated with increased risk for oral infections, dry mouth, and lesions of the oral mucosa. That statement does need to be qualified by another statement, which is there's great variability depending on patient-specific parameters, such as how long has a patient been on medication? What are the comorbidities? What other medications is the patient taking? All of these things are important to take into consideration because it could be that a patient has these immunosuppressive therapies for a long period of time and will have a complete absence of any of the diseases that I'm going to talk about today. It's important to keep in mind. So what I'd like to speak to you on are the conditions, and then more importantly, how to prevent those conditions of the oral cavity in those patients who are on the long-term immunosuppressive therapies. So I have it broken down into common conditions and then less common conditions. Less common conditions are important to talk about because while they are less common, they can be very serious. So I'd like to just say a little bit about dental decay and periodontitis. I think most of us are familiar with cavities. Most of us, unfortunately, have probably had them. How those occur in patients on these drugs most likely is related to the fact that these medications and then being on these medications along with other medications, so-called polypharmacy, can lead to a dry mouth. And the saliva is extremely protective of the dental tissues, of the enamel, and make them stronger and resistant to cavities. So if the mouth is dry from the medicine, you can develop decay. Periodontitis is a little less well understood by most people, but what this involves in is the support of the gum and the bone to the tooth slowly gets eroded away by the presence of bacteria being underneath the gum line. And when that happens, eventually the support to the tooth, the bone and the ligament that's holding it in place begin to erode away. The teeth can become loose and eventually be lost. And that's something that can be prevented. Can be prevented very well. We'll talk about that later. And then also candidiasis. So I'll show a couple images of this. You know, Candida albicans is a commensal organism, meaning a normal part of the microorganisms that live in our mouth. It's a fungus. Most U.S. adults we have it. I probably have it. You probably have it. But in cases of immunosuppression that can be caused by medication, that organism overgrows. It overgrows. And when that happens, it superficially sort of colonizes the upper layer of tissue inside our mouth. So it's really different than an infection. It's not going to cause a fever or anything like that. And some patients are completely asymptomatic with this disease, whereas others will report their mouth feels scalded, like they drank something that was too hot. It feels itchy or has a burning sensation. And there are three types of candidiasis that we see. The first one up here on the dorsal surface of the tongue, just see this red patch. We call that erythematous candidiasis. And then over here on the right side, this is the anterior part of a patient's right inner cheek. And what we see there is this kind of white and red spot. Sometimes it's just white, sometimes it's red and white. And if we were to try to wipe that away, it would be impossible. It's just going to stay. We could try to aggressively touch it with some gauze and push on it. It's not going away. That's hyperplastic candidiasis. And finally, there's pseudomembranous candidiasis. And just want to point out these white and yellow plaques on the dorsal surface of the tongue. Yet if you look closely, you can see them on the patient's palate, and they were present on the inner cheek as well. This being different than The hyperplastic candidiasis, if we wipe this with gauze, it's going to very easily wipe away, leaving a lot of redness and inflammation underneath. And so that's pseudomembranous candidiasis, and sometimes described as if a patient took cottage cheese and sort of rinsed it around their mouth. Okay, then the less common lesions of the oral mucosa: mucositis, ulcerations, oral precancer, and oral cancer. The important thing about this, while they are less common, they can be really serious. And the most important thing in the identifying of a lesion of the oral mucosa, especially on patients who are immune suppressed, is that they have a soft tissue biopsy. Because when I look at an oral mucositis or ulcerative mucositis or precancer or cancer in the mouth, I can't tell the difference between them often, and we have to look at it under the microscope. So getting a biopsy, a little uncomfortable, but the mouth, it heals quickly. Soft tissue biopsy is relatively inexpensive, and it can be the appropriate step that will save someone's life. So very important to pay attention to that. So just like to show you a picture of an ulcerative mucositis. This is the patient's right inner cheek, and you can see this red area of inflammation, ulceration, more ulceration, some crusting of blood, ulceration on the tongue. And as you can imagine, this patient was in some pretty intense pain. I'd like to show you a picture as well of oral cancer. And what we're looking at here is the upper teeth, the lower lip, the upper lip. And here is the tongue, and sort of toward the posterior of the oral tongue, on the right lateral border, is this lesion. And on the center of it, we have some ulceration. Peripheral to that, some red and white speckling, and then this white area. And interestingly, oral cancer can be just a white patch, or it can be just the red and white speckling, or just an ulcer, but this image is helpful because it shows all three of those features. So I did biopsy this. Unfortunately, it was a squamous cell carcinoma, a serious form of oral cancer. And the most important thing now that we come to, and that's mitigating the risks to oral health in patients on long-term immunosuppressive therapies. What can be done with these diseases? The most important thing to realize, the overarching recommendation, is frequent, comprehensive oral examinations. And that's because, number one, when you come in to see the qualified provider, they're going to do a risk assessment. See, are you indeed at risk for these diseases? Do you have a dry mouth? Have any of these diseases begun to occur already? And is there an intervention necessary? So really quickly, for dental decay, we can write an excellent prescription for a toothpaste with a high fluoride content. We know from the literature this is very effective at reducing rates of dental decay. Paying attention, making sure our patients who are already at risk, are they getting adequate hydration to ensure proper salivary flow rates to protect the teeth? And also, how much sugar, simple sugars in the diet, and oral hygiene as well. For periodontitis, we know that this can be prevented by frequent dental cleanings and, of course, appropriate home care. And for patients who already have disease and it's beginning to advance, periodontal therapy, deep cleanings, this kind of thing, very effective at slowing down the disease process and in some cases stopping it. With candidiasis, hydration comes into play as well. But there are a lot of really good antifungal medications that we can prescribe and almost always get patients to a much better spot who are experiencing candidiasis. And lastly, lesions of the oral mucosa, maybe one of the more important things I'm telling you today: soft tissue biopsies whenever these are identified, and that they would be identified on a comprehensive oral exam. So I'd like to end just by giving you an example of a case from a couple of years ago. This was a middle-aged female who was on Celsep, mycophenolate mofetil, for sarcoidosis for a number of years, and her rheumatologist identified this lesion on the right lateral border of the tongue. Again, upper lip, lower lip. This is the tongue and the right lateral border of it. And with a lesion of this size, we didn't want to remove it all because it could have been just a mucositis, not a precancer, because at the time seeing it, we didn't know. But I went ahead and took 3 small biopsies instead of removing it all, because that would have been really uncomfortable and potentially unnecessary. So a biopsy in the back, in the center, and in the anterior. And indeed, under the microscope, this showed serious precancerous changes, specifically called moderate epithelial dysplasia. So that necessitated removal, complete excision, But the fortunate thing is that it's a relatively conservative treatment. And so I drew this I drew this picture around the photo for my colleague, Dr. Frank Weber at Westchester Medical Center, and said, Dr. Weber, I'd like you to go all the way around this lesion to a depth of about 2 to 3 millimeters is all we need, because it had yet to be invasive. It was still a pre-cancer. So this was a really good, made us feel good, Dr. Weber and I, because 3 months later, the patient was doing great. We eliminated pretty much all of disease. And why is this so positive? Well, if this would have sat there for any longer and the rheumatologist wouldn't have identified it, well, that would have meant it could have turned into a full-blown cancer. And a full-blown cancer would have been a much more aggressive surgery. It would have possibly involved chemotherapy and radiation. But fortunately, in this case, just a relatively simple excision that healed rather fast and prevented it from turning into a more serious disease. So again, the strongest recommendation we can make for maintaining oral health in patients on long-term immunosuppressive therapy: frequent, comprehensive oral examinations. Thank you very much for your time, and here are a few of my references.
I want to thank all of our speakers. This is your host again, Dr. Edward Halperin. We have a long list of questions for our panelists today. Oh, we'd better get about our business and answer them. Let's first have Dr. Gandelman and Dr. Yankowski join us live, please. We have a listener who has written, when a person has symptoms which affects their oral health, how are they to know when they come from the autoimmune disease versus the treatment of the disease, or neither? So why don't we take this in opposite alphabetical order? We'll let Dr. Yankowski go first and then Dr. Gandelman.
Well, thank you, Dr. Halperin, and thank you to the contributor for the question. That's a good point to bring out. Well, it is a matter really, in one sense, it can be somewhat difficult to identify whether it's coming from the autoimmune disorder, whether it's coming from the treatment or from something else. And this would require, as mentioned in my short presentation, going to a qualified provider, having a comprehensive oral examination. And during that examination, the provider would make a decision and determine whether this is something that could be related to the autoimmune disorder, the treatment, or something unrelated to those two things. And if it's a lesion, as mentioned, it could be biopsied, and that often gives very clear information. Occasionally, we could also order some serum studies for various autoimmune markers to help determine that as well. And thank you very much. That was an excellent point to bring out.
Dr. Gandelman, anything to add?
Yes, and thank you for this wonderful question. One other thing that I will add in is that it really also depends on the nature of the specific autoimmune condition as well. For example, in multiple sclerosis, we don't often see isolated dental concerns that are due to the disease process. It's more often due to complications of the treatments if that happens. And so knowing what symptoms are most common in that disease process really helps inform the decision of whether it's due to the condition or due to the treatment. Thank you for this question.
Well, let me ask you a follow-up on that, Dr. Gandelman.
Certainly.
I had a conversation about this general topic a couple of months ago with my dentist, and his comment was, with a wag of the finger, those doctors don't even think about this issue enough. You think that's a fair charge against rheumatologists and neurologists and pulmonologists who are handing out drugs for rheumatoid arthritis and lupus and MS, that they don't think about oral health enough?
It's a wonderful question. And I certainly can't speak for all the rheumatologists and pulmonologists and many other neurologists as well. But I can say that I generally think about infection risk, and dental infections are among the most common infections that we see. And so it's certainly something that pops up in my world. So I try to think about it. Thank you for that question.
Thank you. We're going to let you take a break, Dr. Gannon, we keep Dr. Yankowski with us for another question that's come in. The questioner wants to know about what are you folks doing about liquid biopsies for oral malignancies? One hears a lot about looking for malignancies in the blood. Any work on that you'd like to comment on as opposed to surgical biopsies in the mouth?
Sure, another great point to bring out. At this point, the liquid or salivary biopsies for squamous, the main, maybe I'll start off by saying that the main cancer we're talking about in the mouth is oral squamous cell carcinoma. About 90% or more of the head and neck cancers represent that disease specifically, and that's the one that we're usually concerned about in patients who are on immunosuppressive therapies. So how about it's a great question thinking about, well, getting a soft tissue biopsy, who likes getting a needle into their tongue or their inner cheek and getting someone coming toward them with a knife toward their face? It's never a fun prospect. So, hey, could there be some proteins or other markers within the saliva that could help identify? At this point, those items are still under research. We actually have an active research project at New York Medical College and Touro College of Dental Medicine, where we are taking salivary samples of patients at the same time that we take soft tissue biopsies. And then that information, when it is compiled, will be reviewed together. The anticipation with that is what will likely result in is that you might be able to find something that says, oh, there's a profile in this patient's saliva that appears that there could be a precancer or a cancer inside the mouth. It would still require a soft tissue biopsy prior to any surgeon or oncologist of other type doing any kind of oncologic intervention. It's really the standard of care to have a biopsy diagnosis before initiating any anti-cancer therapy. And again, thank you for this excellent question. It's another great point to bring out.
Thank you, Dr. Yankowski. We're going to give you a break and bring Dr. Gandelman back on, please. The question for Dr. Gandelman is, I suppose, on the borderline between a question and a debate. I interpreted the two studies you showed as arguing against discontinuing therapy. One study you showed said that if you stopped early, the rate of events was too high. One study was stopped early because the rate of events was too high in the stopping therapy arm. Then you had another study which showed more MRI lesions in the stop therapy group. Yet when you got to your conclusion slide, you said that de-escalation could be offered to some patients. Weren't you contradicting yourself?
This is a wonderful question, and I thank the listener who brought it up. What I took away from those two studies is that when we look at broad populations, we can't say that everybody can stop medication after the age of 55 or everybody can stop medication after 5 years, because the risk of rebound of disease activity or the risk of further disease activity exists. However, when we think about individuals and we look at their individual risk and benefit, what's going on in their lives, are they experiencing high rates of infection? Do they need to be on a medication that does not work well with their disease-modifying therapy? And have they been stable for years and years and years? When we look into that, or when we think about that on the individual level, there may be times when it is worth de-escalating, albeit with caution. And so for patients where I have that conversation, where we think about de-escalating therapy, I watch them very closely after we stop medication. I don't say, well, you're done with medication, you no longer need the neurologist. We watch them quite closely. We get close imaging. And if we need to reinitiate medication, we do so.
Fair enough. Thank you. We'll give you a little rest and we'll put Dr. Montecalvo on the stand. There's a long list for you. First person who wrote in wants to know if you're going to get the RSV vaccine, how often? Is it one and done, or you need to do it repeatedly?
The RSV vaccine is a single dose vaccine. However, the duration of how long it lasts are still studies that are in progress. So the initial vaccination is one dose, and these vaccines were only recently only recently licensed. And so we're waiting for follow-up data in terms of the duration of protection.
Okay, so the answer is stay tuned. Another questioner wants to know, for a 70-year-old with no underlying medical conditions, should they get the RSV vaccine?
So that's a good question. The recommendations are 60 to 74 if you're at risk, meaning you have cardiopulmonary disease, and over 75 for all adults. But I think what needs to be considered is also whether you're going to be around children. So I think if you have grandchildren, I think if you're 70 and you have grandchildren, I would say to seriously consider it. I think if you don't have any exposures, it's really up to you as to whether you just want that extra level of protection.
Okay. Another person writes, do we have the same concerns about H1N1 in the US as last year? And what are your surveillance recommendations? And I guess you'd better tell our audience what their questioner means by H1N1.
Right. Yeah, thank you. So that gives me a moment to say a few words about flu vaccine. Thank you. So the influenza vaccine, it always has 3 strains covered in it. One is H1N1, which was derived from the swine flu outbreak in 2009. The other is H3N2. Those are both influenza A viruses. And then there's a B strain. Some years we also have the availability of vaccines with a second B strain. So those are called quadrivalents. This year we don't have that. We only have trivalent. And the change this year in vaccine is not in relation to H1N1, it's in relation to H3N2. There has been a modification in that coverage. Regarding current surveillance and what's happening, it's too early to say. New York State issues a weekly surveillance report. There have been about 6,000 cases of influenza in New York State to date, with a hospitalization rate that's under 5%. But it doesn't, strain information is not yet available.
Hey, while we have you, before there's any technical glitches, you wanted to make a point about thimerosal and vaccines that you told me you wanted me to be sure to bring up, people who are concerned about mercury and other issues. So while you have the floor, you should go on ahead.
Oh, thank you. Thanks, Dr. Halperin. So, yeah, so there's been so much press and information about what's going on at CDC, at ACIP, and there's been quite a bit of things that have happened. But I just want to be clear that science hasn't changed. The recommendations are the same. And the one change that is important this year is that all influenza vaccines do not have the mercury preservative thimerosal in them. So that's a major change this year.
Hey, thank you. Let's give you a break and let's bring Dr. Solomon and Dr. Hendricks on, please. Our questioner wants to know, what are the best practice recommendations for the treatment of urinary tract infections in children and in adults? Both of you. Well, Dr. Hendricks mentioned efficacy of antibiotics in UTIs. So let's, since we're talking about who should and shouldn't get antibiotics, let's talk about urinary tract infections in children and adults. And let's take this in alphabetical order. We'll let Dr. Hendricks go first and then Dr. Solomon.
Great. Thank you so much. So urinary tract infections are actually nice infections to treat because it tends to be fairly easy to be able to culture the infections and actually know what bacteria is causing the infection. When you know what bacteria it is, you can really target your antibiotic course towards that bacteria. And so the trend is definitely to provide shorter, more targeted antibiotic courses for uncomplicated UTIs. So even just 3 to 5 day treatments can work as well as longer treatments in uncomplicated UTIs in kids. The shorter courses tend to help reduce resistance, reduce side effects. And of course, it's going to depend on the patient, the type of UTI, and what else they have going on. But the overall best practice is certainly moving towards that. Thank you so much for that question.
Dr. Solomon, for adults?
For adults, it's pretty much the same, very easy to culture and do targeted. Oftentimes, actually, for adults who have had urinary tract infections, we don't even necessarily need to do a urine culture. We typically treat with a short 3-day course of antibiotics for a simple urinary tract infection. For more complicated urinary tract infections, we might do a longer course, but very easy to treat. And that is one place where we generally tend to use antibiotics fairly routinely. There are some women who have asymptomatic infections as they get older, and we don't necessarily treat those infections every time. But for symptomatic people, we generally do a short 3-day course of antibiotics.
Thank you. Okay, but before anybody rushes to the question and answer box and starts typing, let me ask the most frequently follow-up question from previous webinars. What do either of you have to say about cranberry juice? Let's
High in
Tammy go
sugar
first.
and not particularly effective at treating urinary tract infections, so not recommended from my perspective.
Dr. Hendricks, anything to add?
Yeah, I have to agree. I think getting more fluids is really important. If drinking cranberry juice is going to help you to get more fluids, then great. But more fluids in general is going to be something that's going to be recommended. But yeah.
All right. All right, let's let Dr. Lori Solomon have a break, but bring Dr. Solomon Amar on while keeping Dr. Hendricks with us. Okay, we have a cross-disciplinary question. Dr. Amar mentioned that you can measure wastewater for antibiotic resistance. But if pediatricians and wealthier zip codes hand out antibiotics with more frequency than those in poor zip codes, do you see more antibiotic resistant genes in wealthier zip codes? I guess let's start with Dr. Hendricks. Anything you want to expand about the issue of I'm paying for this visit, so I came here to get antibiotics and I'm not leaving without them, doctor. And if I don't get them, I'm taking my cash payments to another pediatrician? Is that
Yes.
basically the message?
We do definitely see, I think for a wide variety of reasons, but certainly some of what you're inferring, we do definitely see more antibiotic prescriptions, more unnecessary antibiotic prescriptions in wealthier neighborhoods. And so absolutely, the wastewater samples are fantastic. It's great to be able to follow those patterns, and wastewater can show antibiotic resistance patterns. However, antibiotic resistance doesn't only occur in wealthier neighborhoods. It's the highest incidences of antibiotic resistance are in neighborhoods where there's overpopulation, overcrowding, more hospital exposure, weaker infrastructure. So it's not going to be as simple as breaking it down to wealthier zip codes, but we do certainly see more unnecessary antibiotics being prescribed in those. Thank you for that question.
Dr. Amar, what do we know about wealth of the neighborhood and antibiotic resistance in wastewater?
I appreciate very much the answer by Tammy. Based on the evidence that we have higher antibiotic prescribing in wealthier areas, if it occurs, could lead to more antibiotic resistant gene. There's no question about that. But in the real world, which is what we measure, we show the complete opposite. shows the poorest zip codes, and that's based on the analysis that we done for a zip code with documented higher pediatric and overall use of antibiotics exhibit a greater antibiotic resistant genes load in the wastewater. That's what we have observed. And this aligns basically in global data where resistance tracks consumption volume that is amplified by SES, disparity in access and hygiene. The intervention like a stewardship program reduce prescribing disparity, but zip code level on wastewater monitoring, and I speak about the CDC and WSS, could test this hypothesis in a more more granularity. But if the premise reflect a specific local anomaly, then we would be able to assess and test this hypothesis. And I appreciate very much this ongoing and live question, which we will come at some point to answer in a more definitive manner.
Thank you. We're going to let Dr. Hendricks take a break, but keep Dr. Solomon Amar with us. The questioner, Dr. Amar, wants to know, says, since you showed a slide about how wastewater measurements could be affected by what is mixed in our water, the questioner wants to know whether fluoridation can interfere with the studies you're describing.
Yes, thank you very much for this question. Very much appreciated. And there's a controversy on fluoridization as we speak nowadays, but water fluoridization produces an acid in the water and introduces, and we've seen it during the COVID infection, a measurable negative bias in wastewater that could be in the magnitude of 7 to 10-fold underestimation in the worst case. We do have ways now to buffer the wastewater and reduce and mitigate this problem, but non-fluoridated water supply give cleaner, more accurate signal for those particular pathogens. I appreciate also very much the question.
I suppose we'd better parse the distinction that that's not a reason not to fluoridate.
Oh, absolutely, absolutely. I preface that, yes.
Yeah. Thank you. We're going to give you a break, and let's bring Dr. Gandelman back on, please. The question relates to a mixture of what you discussed and what Dr. Jankowski discussed when he showed the case of the pre-malignant lesion in the patient treated for sarcoidosis. The questioner wants to know that since you are administering drugs which affect the immune system, is there a concern about second malignant neoplasm induction for leukemia or lymphoma in MS patients from these drugs which are now being used as disease-modifying drugs?
Thank you for this question. It's a wonderful question. So among all of the disease-modifying therapies for MS, among the 20 in the class, there are quite a few different mechanisms of action. Some of them do not increase the risk of malignancy. A couple of them can increase risk of malignancy. The S1P modulators have had some evidence showing an increased risk of squamous cell carcinoma of the skin, which is why we recommend annual dermatologic screening for patients on these medications. But specifically for leukemia and lymphoma, there's not been a substantially higher rate of those two particular cancers among all disease-modifying therapies. There are a few different medications that can increase the rate of malignancy in general, slightly increase the rate of malignancy in general. And so we are cautious with giving those medications and thinking about those medications. But this is something that we certainly think about.
Thank you. While we have you on, is there anything you want to add to the answers given by Dr. Hendricks and Dr. Laurie Solomon about urinary tract infections for MS patients, since many MS patients have urinary tract symptoms?
Yes, this is a wonderful question, and I'm glad that it was brought up. For people living with multiple sclerosis, particularly people with higher disease burden in their spinal cords, we can often see an increased rate of urinary tract infections as compared to the general population. And so this is something we often see in our patient population. However, there's no difference in antibiotic prescribing practices or in how we approach treatment of those UTIs in general. We are just more vigilant, I'd say, than we are in patients who do not have multiple sclerosis. Thank you for this question.
Thank you. I'll ask all our panelists to put their cameras back on. The time, as usual, has flown by. It is 1:30 Eastern Time. We've gotten to as many of your questions as we could in the time available to us. Thanks for joining us on 90 Minutes, the medical magazine of the web from Touro University and New York Medical College. If there are topics that you want to see in future webinars, please go ahead and type them in the Q&A box now. But otherwise, we wish everybody a good day. Stay safe and healthy. Everyone have a good set of holidays coming up. Take care. See you next time.